Good morning. I am Dr. Lavesh Agarwal, Associate Professor and Dex Medical College, Orthopedic Department. So today we are discussing neck of femur fractures. This is very dynamic topic for all UG and PG students because neck of femur is very common in old age patients after 50 or 60 years when patient suffering with comorbidities, diabetes, blood pressure, osteoporosis, especially in female patient when they are their menopausal phase. So there will be a severe osteoporotic conditions just because of hormonal disturbance. So increased chances of femur fractures. So our topic is neck of femur fracture. Epidemiology. In elderly, typical neck of femur fractures result from low energy fall and associated with osteoporosis. As I already told, osteoporosis in male and female is very common after 50 or 60 years. In female patients, menopausal stage started, so there is a hormonal disturbance and osteoporosis occurs. Young typical neck of femur fracture result of high energy mechanism and other associated injury are common. Mostly intracapsular and compromised blood supply of head of femur. Intracapsular and extracapsular. Two varieties are in fracture femur. We'll discuss later in slides also. But now requirement of understanding means mostly intracapsular and compromised blood supply of head of femur result in fracture neck of femur. Risk factor. Female is more susceptible to neck of fracture femur rather than male. White race, increasing age, definitely in senior citizen, osteoporosis incidence is more. So osteoporosis is more and risk is more for fracture neck of femur. Poor health. Fracture neck of femur associated with comorbidity of the patients. Fracture neck of femur always associated with osteoporosis, which accumulate just because due to poor health. Tobacco and alcohol use also a predisposing factor. As we know, alcohol and tobacco increase incidence of osteoporosis. So when osteoporosis is there, always risk factor increase for fracture neck of femur. History of fall. When patient had a history of fall, so definitely increase chances of fracture neck of femur. low estrogen level. As we discuss in menopausal phase, female has a low estrogen level. Endometriosis occurs, estrogen levels decrease, and osteoporosis increase and increase chance of fracture. Neck of femur. Anatomy. The upper femoral epiphysis close by the age of 16 years. Neck shaft angle 130 plus minus 5 to 7 degrees. Femoral and diversion 10 degree plus minus 5 to 7 degrees. Three ligament attach in this region. Iliofemoral ligament of bilo or anterior, pivofemoral which attach to anteriorly, and posteriorly attached to ischio-femoral. So three main ligament attach in this region: anterior, posterior, and again anterior iliofemoral ligament. So anteriorly attached with pubis symphysis to femoral, right? So pubis-femoral ligament attached to anterior, and ischio-femoral ischium attached to femur by ischiofemur, and iliofemur, ilium, ischium, and pubis are all three are attached to femoral bone by anteriorly and posteriorly. Calcar femoral, a vertically oriented plate from the posterior-medially portion of the femoral shaft, radiating superiorly toward the greater trochanter. As we know, there is a head and neck, calcar, and shaft. So there is a angle shaft which already discussed, neck shaft angle. This is neck shaft angle is a 130 degree. So vertical oriented plate from the posterior portion of the femoral shaft. This is a femoral shaft. So femoral shaft portion of posterior-medially plate vertically oriented, radiating superiorly toward the greater trochanter. So this is a shaft and posterior-medially toward the greater trochanter. Now, blood supply. Blood supply. Major contributor is medial femoral circumflex artery. This is a medial circumflex artery. As we know, there is a major common femoral artery, which contribute as a lateral circumflex and medial circumflex. So major contribute is medial femoral circumflex artery, which is a branch of main femoral artery. So medial femoral circumflex artery. Some contribution to anterior and inferior head from the lateral femoral flex. So medial femoral circumflex artery, lateral femoral circumflex artery. So this is a shaft, neck, and head. So supply by the femoral artery, and medially is The major parts of medial femoral circumflex artery and lateral circumflex artery. Some contribution from inferior gluteal artery, small and insufficient or insignificant supply from the artery of ligamenting teres. So you can see in this picture, this is common femoral main trunk which contribute lateral circumflex artery and medial circumflex artery. So medial is main contributor and second one is lateral circumflex. So when neck of fracture femur is there, this is neck of fracture femur. So blood supply distorted as a medial and lateral. In similar case, when there is a AVN, avascular necrosis of head. So these blood supplier are also compromised due to many regions. So this is main blood supply of a sharp neck and head of the femur. Now come on classifications. Classify location of fracture line. This is a picture of fracture neck femur and classification depend on the location and fracture line means subcapital, transcervical or basic cervical. So this is a neck and this is a shaft. So this is a neck. When a line draw in this way, this is a subcapital fracture, right? When line draw a transverse plane, this is a transcervical means fracture neck femur occurs at the middle of the neck. Yes, this is transcervical. And last one is basic cervical. Yes. When fractures occur at the base of the neck, so this is basic cervical. So this is the first classification, depend on the location of fracture. First one is subcapital, second one is transcervical, and third one is basic cervical. So subcapital, transcervical, and basic cervical. So these three classes sub-classify according to location of fracture line. So you can see in this picture, this is a head, right? This is a head. This is the neck, and this one is a shaft. So when fracture line goes through these planes, this is known as subcapital. So this is subcapital fracture. When the line grow at the mid of the neck. So this is transcervical. And when the fracture occur at the base of line, yes, so this is basic cervical. So this is depend on the location of fracture line. So this was the first classification. depend on the location of line, right? Second one is gardens classifications. Gardens classifications most commonly use classification systems. This is based on the degree of displacement. How displaced of the fracture neck femur. So this is the based of degree of displacement. Gardens classifications is based on AP pelvis radiograph, means X-ray pelvis with both hip on AP view, depend on the Gardens classifications. Stage first, incomplete fracture line, valgus impacted. Yes, incomplete fracture line, valgus impacted. Stage 2, complete fracture line non-displaced. Incomplete fracture line, this comes under category of stage 1 of Gardens classifications. You can see in this picture the fracture line is not completed to other cortex. So this was stage 1. Stage 2, a complete fracture line but non-displaced fracture. So undisplaced but complete fracture lines comes in category of second. Stage third, complete fracture line partially displaced. So this is stage third. Stage four, complete fracture line completely displaced. So you can summarize in four stages: first, second, third, and fourth. This is totally based on the degree of displacement. Fourth one is an advanced stage, complete fracture line with complete displaced fracture. And first one is non-complete fracture line, non-displacement. And second stage is complete fracture line but non-displaced. And third one is complete fracture line partially displaced. So this is a stage 1, 2, 3, 4. Again divide into a percentage wise 25%, 50, 75, 100. So mild, moderate, severe, advanced. And you can say stage 1, stage 2, stage 3, stage 4. So stage 1 is non-complete fracture with non-displacement. Fourth one, advanced stage is complete fracture line with completely displaced. In summarize, in this way, incomplete fracture line, complete fracture line. So except stage 1, all stage having complete fracture line, and except stage 4, no one category is having completely displaced fracture. So stage 1, stage 2, stage 3, and stage 4. So you can say stage 4 is advanced stage in fracture femur neck, in which complete fracture line with complete displacement of the fracture. Now come on the third classification, as a Powell's classifications. So Powell classifications is based on the angle. A fracture neck femur classified in three different type of classifications. First one is location, depend on the location of fracture line. Second one is depend on the degree of displacement. And third one is Powell's classifications based on the angle. The fracture line make in reference to horizontal. Type 1, type 2, 3. Fracture is between 0 and 30 degree in reference to horizontal. Type 2 between 30 and 50 degree. Type 3 more than 50 degree. So 0 to 30, 30 to 50 and more than 50 degree. So 0 to 30 is a type 1 as a Powell's. 30 and between 30 and 50 degree comes in category of type 2 and more than 50 degree and type 3. Trabeculae pattern of proximal hip. Trabeculae pattern of proximal hip. In this slide, you can see the trabeculae pattern of fracture neck. This is a principal tensile group. Principal tensile group of trabeculae. This is principal compressive group. So principal tensile group, principal compressive group, greater trochanter group, and secondary tensile group. So first one is tensile group, second one is compressive group, which again divide into a two group, principal and secondary. So principal tensile group initially start with greater trochanter in linear manner and progress up to the head of femur. So this is principal tensile group. Secondary tensile group, you can see in lesser troch and greater troch. Principally compressive group in this manner and secondary compressive group in this manner. So trabeculae pattern of proximal hip is compressive trabeculae and tensile trabeculae. Compressive trabeculae again divide into a principal and secondary. Tensile group again divide into a principally and secondary group. Diagnosis. Diagnosis is based on history, physical examinations, and X-ray, radiograph. History of a traumatic event with the exception of the patients who have stress fracture of a femoral neck. In femoral neck, some degree of fracture Stress fracture is seen in which no major history of trauma is there, but mostly cases in young patient fracture neck femur, there is a history of traumatic event, or in elderly patient or senior citizen patients, there is a typical history of slipping of foot, slipping of leg in washroom or somewhere in a home. So this is a typical traumatic history pattern in senior citizen patients or elderly patients, not much having travel trauma, but young patients with high energy femoral neck fractures have associated injuries, including head injuries and missed femoral neck fractures can be distorted. So this is a typical history of any event. This is a clinical picture or physical examination. On examination, extremity is shortened and externally rotated. Typical attitude of limb. This goes as externally rotated limb and shortening of the limb. So this is physical examination findings when other limb is normal in neutral rotation, but affected limb or fractured limb lie in external position and shortening of the limb. So when you examine the patient lie in supine position with the limb as in external position and shortening of the limb. So on spot, diagnosis is suspected fracture neck of femur, maybe endotraumatic fracture, but most commonly found in this finding is fracture neck of femur. Radiograph, we can advise standard AP pelvic view, cross table lateral view, traction internal rotation view. The entire femur should be imaged. The most common X-ray when we prescribe in suspected neck of fracture femur is PBH, pelvis with both hip AP view. Second is cross table lateral view. Traction internal rotation view helpful to diagnose the undisplaced or partially depressed fracture. When the traction given in internal rotation, so they are seen a clear cut fracture line. For other fracture, you should always rule out other associated fracture. So always do entire femur should be imaging. Means should be taken full length X-ray. Bone scan always helpful to rule out occult fracture. not helpful in reliably assessing viability of femoral head after fracture. So, first investigation is definitely in respect to a treatment. X-ray should be done with APB. X-ray should be taken full length X-ray of femur to avoid any associated deformity or any other fracture except along with fracture neck of femur. Bone skin, no treatment part. Treatment part depend on the close reduction, open reduction, fluoroscopy. Close reduction. A close reduction can be attempted in every patient for whom internal fixation is planned. Flow reduction is a technique in which less chance of bleeding, less chance of exposure, less chance of infections, fast recovery because most of the patient comes with comorbidity with heart problem, sugar problem, lungs or kidney problem. So you have to choose flow reduction technique in every cases. So how we flow reduction is achieved? This is done by Whiteman technique. Whiteman technique is a simple applied traction to abducted, extended, externally rotated hip with subsequent internal rotation. Applied traction to abducted, extended, externally rotated hip with subsequent internal rotation. So, when you do floor direction attempt, should not be forceful, should not be repeated more than 2 to 3 times because always chance of more displacement. So should not be repeated more than 2 to 3 times. Should not be forceful. Once reduction has been attempted, the angulation and alignment must be critically evaluated because when you do attempt of load reduction, you should always check the angulation and alignment must be critically evaluated. Angulation and alignment. How evaluated? Why the garden alignment index? Yes, garden classifications. The base depend on displacement or degree of displacement. So, angulation and alignment always evaluated by the garden's alignment index. So, what is garden alignment index? Garden alignment index is when you do AP X-ray, the angle between the medial shaft and central axis of medial compressive trabeculae should measure between the 160 and 180 degree. If you remember the medial compressive trabeculae, just I can try to trabeculae pattern to revise. Yes, in previous slide, this is a trabeculae pattern, compressive trabeculae pattern, right? So, garden alignment index, the angle between the medial shaft. This is a shaft, this is a neck. So this is the medial shaft and central axis of medial compressive trabeculae should measure between the 160 and 180 degree. Less than 160 degree indicate varus and more than 180 degree indicate valgus. So never fix in varus or valgus. Always when you do attempt for flow direction, you should always check the displacement and alignment according to Cardan alignment index, which is simply seen in AP view. In AP view, when you see the trabeculae pattern or measurement, medial shaft, central axis of medial compressor trabeculae 160 to 180. In varus indicate less than 160 degree and valgus 180 degree. Garden alignment index. You can see this is medial shaft and central axis, right? So this is medial shaft and this is central trabeculae. This angle, medial shaft and central axis of neck, is known as Cardan alignment index. When fixed in varus, so angle reduced below 160, and when fixed in valgus, so angle in more than 180. Yes, this is a radiograph. Angle between the medial trabeculae seen in femoral head and medial cortex of femoral shaft. Yes, femoral head and medial cortex of femoral shaft. Medial cortex. This is a medial cortex of femoral shaft. Right? This angle is 160 to 180. 160 is for less than 160 is known as chorus, and when angle increase more than 180, this is a valgus. Now treatment is non-operative and operative. Non-operative treatment considered in some patients who are non-ambulators or having minimal pain or high risk of surgical intervention. The patient who are not medically fit or already non-ambulatory or having minimal pain is an ideal candidate for non-operative treatment. In which patient sugar is too high, HbA1c more than 10, creatinine is more than 1.5, or some other comorbidity which contraindication for surgery or medically non-fit patient are ideal candidate for non-operative treatment who are already non-ambulators or have a minimal pain or high risk of surgical intervention. Now, operative treatment. Operative treatment means ORIP. ORIP means open reduction and internal fixation. Indication: displaced fracture in young or physiological young patient. If you are finding X-ray, there is complete displacement or complete fracture in young patients or elderly patients, but who are medically fit, who are medically fit, they are ideal candidate for open reduction and internal fixation. Low energy, fragility, fracture in elderly patients. Most patients at the age of 65 years of age, as 65 to 85 years of age, open reduction, internal fixation for guidance first and second pattern Physiological young patient with garden third and fourth, age more than 85, treated with 4A4 gardens and so treatment wise, you have different type of modality in which cannulated screw fixation, cannulated screw fixation is ideally indicated in non-displaced transcervical fracture. Non-displaced transcervical fracture. Displaced transcervical fracture in young patients achieve reduction to limit vascular insult. Reduction must be anatomical open if necessary, but in every case, reduction must be anatomical because cannulated screw fixation is ideally indicated in non-displaced cervical fracture. So transcervicals means according to first classification, it's totally depend on the location of fracture means middle of neck line fracture line grow middle of neck. So this is known as a transcervical fracture. Displaced transcervical fracture in young patient. This is the picture. Three partially threaded screw can be inserted in what inverted triangular configuration. Three partially threaded screw can be inserted in which position? Inverted triangular configuration. Inverted configurations means this is a draw line. This is the line, fracture line in different plane in same form. Two screw insert in this position in anterior posterior different plane, and this was inferior. So superior two screw and inferior one screw. So inserted in inverted triangular configuration. Four screw can be placed in diamond configuration when significant communication is present. Four screw can be placed in diamond configuration when significant communication is present. Fixation of neck of fracture with cannulated screw. Extreme care must be taken in placement of guided pins. subtrochanteric femoral fracture. Fixation of neck of fracture femur with cannulated screw. Extreme care must be taken in placement of guided pin. Fix with an apex distal screw or apex proximal screw configuration. Apex distal configuration exhibited a greater load to failure. Sliding hip screw or cephalomedullary nail. Indications: BC cervical fracture. BC cervical fracture, you can remember when we discuss classifications of fracture. So this was the depend on the location of fracture line, base of the neck. So this is the basic cervical fracture. The basic cervical fracture is most common indication in sliding hip screw or nail. Yes, fracture neck femur. Basic cervical just near to trochanteric line. So you can insert the nail or sliding hip screw. Considered placement of additional cannulated screw above sliding hip screw to prevent rotation. Ipsilateral to femoral shaft fracture with compressive hip screw and derotational screw is also put just above the sliding screw to avoid rotation of fracture fragment. When we fix derotation screw, so we can avoid the rotation of head movement. When rotation is avoided, then easily fix with compressive hip screw. So basic indication is basic cervical fracture and consider placement of additional cannulated screw above sliding hip screw to prevent rotation. In this picture, you can see the sliding hip screw with rotation screw to avoid rotation of hip fracture fragment and sliding screw to work as a compressive and alignment device for fracture femur. When derotation put, then slide screw. So as the name of sliding screw, when you tighten the Richard main central screw, the compression is there, and all compression set in their own journey. So fixed weight compression head is screw and the rotational screw. Now orthoplasty. When fracture neck femur occurs, totally displaced fracture, complete fracture line, sliding screw cannot be inserted in such manner. If you see or if you examine the patient and read the X-ray and salvage is not possible, then go for arthroplasty. Arthroplasty may be a two type, total hip orthoplasty or hemi arthroplasty. Above six, below 65 years of age should be treated with anatomical reduction and stable internal fixation. And displaced femoral neck fracture in older patients should be treated with orthoplasty. Arthroplasty most commonly indicated in stage 4th power classifications or gardens also indicate 4th stage in which complete displacement is occurs. Controversial issue type of arthroplasty, hemi arthroplasty or total hip arthroplasty, unipolar or bipolar, cemented or uncemented, femoral stem, surgical approach. So this is controversial issue in surgery of fracture neck femur patient. You can do hemiarthroplasty when you can do total hip replacement or total hip arthroplasty. No clear cut criteria for absolute hemiarthroplasty or total hip orthoplasty. This is based on the many fractures, many fracture pattern and many factors, just like age, type of fracture, quality of bone, degree of displacement, osteoporosis content, comorbidity of patients, etc. So type of orthoplasty is totally depend on the surgical approach and requirement of patient. In requirement, if patient is young patient, so always try to do growth reduction first. If growth reduction is not possible, then go for ORIF, open reduction, internal fixation. Then last one is choose for orthoplasty. In orthoplasty, unipolar, bipolar, cemented or uncemented. In young patient, always try to uncemented implant, and elderly patient when there is huge amount of osteoporosis, so always try to put in a cement fixation. So in elderly patient or senior citizen patient, you can put the cement with your choice implant. Hemi-arthroplasty. Hemi-arthroplasty, indication, controversial, debilitated elderly patients, metabolic, bone disease, total hip arthroplasty, controversial, older active patients, arthroplasty for gardens, third and fourth in patient, more than 30 years, 85 years. Potential benefit of total hip orthoplasty over hemiarthroplasty. Decrease pain, improved ambulation, low reoperation rate. The disadvantage of total hip orthoplasty appears to be a higher, slightly higher acceleration rate. Complication of urethra, non-union, osteonecrosis, fixation failure, dislocation, motility. Non-union, incidence of 5 to 30%. Increase incidence in displaced fracture, varus,
The number you have dialed is currently busy.
osteonecrosis, treatment, valgus intertrochanteric osteotomy, free vascularized fibula graft, orthoplasty, or division orif, osteonecrosis. Up to 10% of non-displaced and up to 30% of displaced fracture. Not all cases developed evidence of radiographic collapse. Treatment is guided by symptoms early without X-ray change, protected weight bearing on possible core decompression, laid with X-ray change, elderly individual may be treated with orthoplasty, whereas younger patient may be treated with osteotomy, arthrodesis, or arthroplasty. Fixation failure. This is usually related to osteoporotic wound or technical problem, malreduction, poor implant insertion, treatment. It may be treated with attempt repeat, open reduction, and internal fixation or prosthetic replacement. Dislocation, higher rate of dislocation with orthoplasty, about 7 times higher than hemi-orthoplasty. Motility. Mortality in last point with chronic renal failure, rates of mortality at 2 years postoperatively are close to 45%. So thank you so much. Thank you so much for answering.